Genetic and Congenital Disorders, Module 2. I am Dr. Williams, and I will be doing an introduction into genetic and congenital disorders. In this lecture, I hope to introduce you to some areas that will assist you in your studies of genetic and congenital disorders. This lecture is meant to introduce you to some concepts and some disorders, and then you should utilize your textbooks and other resources to enhance your knowledge about the specific details and the pathophysiology related to some of these genetic and congenital disorders. Let's begin by, so what are the objectives we are going to cover in this lecture? We're going to talk about the structure of genes, the pathophysiologic aspects of genetic disease. How does the genetic disease actually present itself? What are the mechanisms that contribute to the mutations that occur leading to genetic and congenital disorders? And at what rate do we see these congenital and genetic disorders in the United States? We must start off first, though, talking about the terminology of the genetic and congenital disorders. There are many terms that are utilized on this subject that you must have a clear understanding of in order to grasp genetic and congenital disorders. Terms such as homozygous, heterozygous, gene mutations, alleles. So when we talk about heterozygous and homozygous, we are talking about having two alleles that are on the same locus, and they are either at a different or those alleles are the same. If the two alleles at the same locus are different, they're considered heterozygous. If the two alleles that are on the same locus are the same, they are considered homozygous. So you will hear these terms and see these terms as you read in your textbook about congenital disorders. So it will be a great time for you to take a moment, stop the recording, go to your Hammer and McPhee textbook and look at table 2-1. There are many concepts and terms that are listed there that will help you as you begin to read about the different genetic and congenital disorders. Let's talk about causes of birth defects, or what they also refer to as congenital defects. Congenital defects or birth defects is abnormalities of the body structure, function, or metabolism that is present at birth. In the United States, we see about 185,000 infants discharged from hospitals with congenital defects. Congenital defects are usually caused by three different factors. There are three factors that we want to talk about related to birth defects. Genetic factors, which can be multifactorial, environmental factors, which can impact how the fetus develops, and there are multiple causes for that, and intrauterine factors, which are rare factors that can also contribute to congenital defects, or what we also term as birth defects. So let's start by talking about genetic and chromosomal disorders. Genetic and chromosomal disorders is when or caused by changes in the deoxyribonucleic acid or DNA sequence. And that change alters the synthesis of a single gene product, leading to chromosomal aberrations such as deletions, duplications in error, or due to abnormal number of chromosomes. When we talk about genetic and chromosomal disorders, we're going to talk about it from a single gene disorder, which includes autosomal dominant disorders, such as Marfan syndrome, neurofibromatosis, and then we have autosomal recessive disorders, including things like phenylketonuria, Tay-Sachs disease, and then we also have X-linked recessive disorders, X-linked dominant disorders. We have Fragile X syndrome, and then we have things that can also be multifactorial. So let's just start off with talking about some of the causes of the genetic and chromosomal disorders. Characteristics of a single gene disorder can be caused by a single defective or mutant gene. It can follow the Mendelian pattern of inheritance, which was established by scientist Gregor Mendel back in 1865, when there was the identification of genes as dominant or recessive, and where we now understand homozygotes and heterozygotes. That all came from Mendel's law. And then also, they're characterized by the pattern of their transmission. How does it transmit from family history? What are the results of a single gene disorder? Formation of abnormal proteins or decreased production, defective or decreased amounts of enzymes, defects in the receptor proteins and their function. You can alter or alterations in non-enzyme proteins, and then mutations resulting in unusual reactions to drugs. We're talking about disorders of single gene inheritance, Mendelian's law. We're talking about that autosomal dominant, autosomal recessive, and the X-linked recessive. Autosomal dominant disorders. We'll start by talking about osteogenesis imperfecta. Osteogenesis imperfecta is a heterogeneous and pleiotropic group of disorders characterized by a tendency towards bone fragility. It is classified into 4 different types. When we talk about the types of osteogenesis imperfecta, type 1 or type 4 can present in early childhood with 1 or a few fractures of long bones in response to minimal or no trauma. The X-ray films may reveal mild osteopenia, little or no bony deformity, and often evidence of early subclinical fractures. When we think about individuals with type 1 osteogenesis imperfecta, they typically have the blue sclera, whereas the sclera of those in type 4 are normal to or gray. Type 2 osteogenesis imperfecta presents at or before birth. It can oftentimes be diagnosed in prenatal imaging with multiple fractures, bony deformities, increased fragility, and non-bony connective tissue, and blue sclera, and usually results in death at infancy. Type 3, unlike the other forms of osteogenesis imperfecta, which is nearly always due to variants that act dominantly, this type 3, may be, and it's rare, but it may be a recessive manner. Now let's talk about Marfan syndrome. Marfan syndrome is a connective tissue disorder manifested by changes in the skeleton, the eyes, and the cardiovascular system. It is basically a biochemical abnormality that affects fibrillin 1, a major component of microfibrils found in the extracerebral matrix. Marfan syndrome can usually affect several organs, which can include the eyes, the cardiovascular system, the skeletal system, and it can have a wide range of variations in the phenotype for this disorder. The most common feature that you'll see is skeletal deformities with Marfan syndrome. You'll see deformities of the chest. It can include pectus excavatum, and that's when there is this deep indentation in the chest. Or you may also see individuals with a pigeon chest. Usually, the chest deformities require surgery for correction. And the most common eye disorders that you will see in individuals with Marfan syndrome can either be dislocation of the lens because of the weakness of the suspensory ligaments, or they may have myopia. When we think about life-threatening aspects of the Marfan syndrome, you think of things that impact the cardiovascular system: mitral valve prolapse, progressive dilatation of the aortic valve, or weakness of the aorta. You can even get dissection and ruptures of aortas. Now, when you talk about neurofibromatosis, this is a disorder or a condition that causes many tumors to develop from the Schwann cells of the neurologic system. There are at least two genetically distinct forms of neurofibromatosis, known as type 1 and type 2. Type 1 is the common disorder. It's characterized by cutaneous and subcutaneous neurofibromas that develop late in childhood and adolescence. These neurofibromas can vary in size and number. And the second aspect or major component that you'll see in neurofibroma type 1 is sometimes you can get flat cutaneous pigmentation, looks like cafe au lait spots. And they're usually pretty significant in size. They say greater than about 15 millimeters in diameter. They're usually uniform. And then you may also see children with neurofibroma type 1. They can have neurologic complications, such as learning disabilities, attention deficit disorders, abnormalities in their speech. Now, when you talk about neurofibroma type 2, these individuals are characterized by tumors of the acoustic nerve. They normally become asymptomatic. They're normally asymptomatic through the age of 15. At age 15 is where you may start to see their symptoms. You see type 2 less frequently than you do type 1, and it occurs at a rate of about 1 in every 50,000 people. The most common symptoms or frequent symptoms you'll see with type 2 neurofibromatosis is headaches, hearing loss, and tinnitus. You can also get some associated intracranial and spinal meningiomas. And these individuals may need to have surgical intervention to do some debulking to remove those tumors. Phenylketonuria. Phenylketonuria, also known as PKU, is a rare autosomal recessive metabolic disorder that affects approximately 1 in every 10,000 to 15,000 infants in the United States. It's caused by a deficiency of the liver enzyme phenylalanine hydroxylase. And because of that, it allows toxic levels of amino acid phenylalanine to accumulate in tissues and the blood. If it goes untreated, this disorder results in mental retardation, microcephaly, delayed speech, and other signs of impaired neurological development. Because the symptoms progress so gradually, it is important that infants are assessed for PKU early. Thus, it is a test that all infants are assessed for at birth. The treatment for PKU is a restriction on foods that contain phenylalanine. If we do not restrict their diet for this, then these infants can eventually get mental retardation and neurodegenerative effects. Treatment also for any infant who is found to have a high level of phenylalanine. These individuals have to be treated within 7 to 10 days after diagnosis or after birth. Let's move now to Tay-Sachs disease. Now, Tay-Sachs disease is a variant of a class of lysosomal storage diseases, also known as gangliosidosis, in which there is a failure to break down the GM2 gangliosides of cell membranes. It is inherited as an autosomal recessive trait and occurs 10 times more frequently in Eastern European Jews. Infants with Tay-Sachs disease appear normal at birth. They begin to manifest progressive weakness, muscle flaccidity, and decreased responsiveness at approximately 6 to 10 months of age. It is then rapidly followed by deterioration of the motor skills and mental function. They can also begin to have generalized seizures, retinal involvement, which leads to visual impairment. Infants with Tay-Sachs disease usually die between the ages of 4 and 5 years old. So how do we assess or evaluate for Tay-Sachs? It is through blood serum, looking for lysosomal enzymes. The enzyme that we're looking for is hexosaminidase A. Hexosaminidase A is the enzyme that you look for in blood serum. There will be a deficit if an individual has Tay-Sachs disease. So it's important to try to accurately identify individuals who are genetic carriers for Tay-Sachs disease and educate them and inform them about their risks of transmission to their children. X-linked disorders. What are X-linked disorders? Although they are not common, X-linked recessive disorders do exist. There are also X-linked dominant disorders. When we talk about Fragile X syndrome, it is a single gene disorder that causes intellectual disability. It is a mutation that occurs at a fragile site, the XQ27 site, and is characterized by amplification of cytosine, guanine, and guanine repeat, which is referred to as CGG. The disorder affects about 1 in 1,250 males, where it affects about 1 in 2,500 females. So males may present with Fragile X a little more than females. And the most common form is an inherited intellectual disability. So what does an individual present like? What would Fragile X syndrome, what are some clinical manifestations and how is it diagnosed? When we think about boys who are affected by Fragile X, it's usually an intellectual disability. Because they share a common physical phenotype that includes a long face, long mandible, and large everted ears. They can have hyperextensible joints and a high arched palate. They may even present with mitral valve prolapse, which can mimic some connective tissue disorders. They may or may not have physical abnormalities. They don't always have to be present. That is some of the clinical manifestations in boys. When we talk about clinical manifestation in girls, what we normally see that they may be relatively normal cognitive wise, or they may show a learning disability in a particular area. So how do we diagnose Fragile X syndrome? It's usually based on mental and physical characteristics. You can do DNA tests to confirm the presence of the abnormal gene. And because Fragile X kind of resembles other learning disorders, it is always recommended that people who have any type of intellectual disability, such as autism, developmental delays, learning disabilities, that you may consider screening them for Fragile X. Let's talk about some multifactorial inheritance disorders. Multifactorial disorders are caused by the influence of multiple genes along with environmental factors. These traits do not follow the same clear-cut pattern of inheritance as do single gene disorders, because the appearance of the disorder phenotype will be dependent on environmental changes in addition to genetic mutation. Disorders of multifactorial inheritance can be present at birth, or they can be expressed later in life. Congenital disorders are thought to arise through multifactorial inheritance, which includes things like cleft lip or palate, clubfoot, congenital dislocation of the hip, congenital heart disease, pyloric stenosis, and urinary tract malformations. Let's talk a little bit about individuals who experience these multifactorial disorders. It is important to educate the mother that if they have a child who has one of these multifactorial inheritance disorders, their future children are at increased risk of having that same disorder. The risk increases with the increasing number of incidents of the defect among relatives. It's also important to note with multifactorial inheritance disorders, the environmental factors that also play a role in these disorders can develop later in adult life. Disorders that you may see based on environmental factors later in life include things like coronary artery disease, diabetes mellitus, and hypertension and cancers. So if we think about, now just talk about cleft lip and cleft palate. Cleft lip with or with a cleft palate is one of the most common birth defects. It occurs in about 0.1% of all pregnancies. It results in abnormal facial appearance and defective speech. The defect has its own origin at about 35th day of gestation, when the frontal prominences of the craniofacial structures fuse with the maxillary process to form the upper lip. This process is under the control of many genes, and disturbances in these at any time may result in a cleft lip, with or without a cleft palate. A child with cleft lip or cleft palate may require years of special treatment by medical and dental specialists, including plastic surgeons, pediatric dentists, orthodontists, and speech therapists. We have made major advances in the care of children who are born with cleft lip and palate. These children can undergo surgical procedures that will close the lip, and they can usually have this procedure done at about 3 months of age. And that's for a cleft lip. If you're talking about the closure of a cleft palate, usually about 1 year of age is when that may occur for them. So there are treatments out there for infants who may be born with a multifactorial disorder. Chromosomal disorders form a major category of genetic disease. It accounts for the largest proportion of early miscarriages congenital malformations, and intellectual disabilities. So whereas in the process of replication, we should get a set of 23 individual chromosomes from the ovum and a set of 23 chromosomes from the sperm, which should equal a total of 46 total chromosomes to be produced for the offspring, somewhere there's an abnormality that happens in that process. That aberration and abnormality leads to either a breaking of the structure, it can be a rearrangement or a deletion, and thus leading to a chromosomal disorder based off of structure. Let's briefly talk about a few of the chromosomal disorders you will see related to alterations in chromosome numbers. We'll start with talking about Down syndrome. It is reported that 95% of cases of Down syndrome are caused by non-disjunction or an error in cell division during meiosis. It results in a trisomy of chromosome 21. The risk of having a child with Down syndrome increases with maternal age. There are some physical attributes or characteristics that become evident at birth with a child who has Down syndrome. Some of those features include a flat facial profile. They can have depressed nasal bridges, malformed ears, a fat pad in the back of their neck, fingers that curl inward, just to name a few. There are some prenatal screening tests that can be performed. Those tests include an alpha fetoprotein, human chorionic gonadotropin, unconjugated estriol, inhibin A, and a pregnancy-associated plasma protein A. The results of the 3 or 4 of these tests together with the woman's age often are used to determine the probability of a pregnant woman having a child with Down syndrome. Between 10 to 13 weeks, women can have an ultrasound that assesses the nuchal translucency for Down syndrome. When we talk about, let's move to Turner syndrome. Turner syndrome describes an absence of all or part of the X chromosome. Some women with Turner syndrome may have part of the X chromosomes, and some may display a mosaicism, where one or more additional cell lines are active. The disorder affects about 1 in 2,500 live births and is most frequently occurring genetic disorder in women. So what are some of the characteristics you may see with someone with Turner syndrome? They can have short stature, but their body postures are normal. Females can lose the majority of their oocytes by the age of 2. Therefore, they do not menstruate and they show no signs of secondary sex characteristics. Because the phenotype can be somewhat variable, the diagnosis of Turner syndrome often is delayed until childhood or early adolescence. How do we manage Turner syndrome? It requires ongoing assessment and treatment. It's not a one-time treatment. Growth hormone therapy generally can result in a gain of 6 to 10 centimeters in final height. These individuals may receive estrogen therapy, and it's usually instituted around the normal age of puberty. It helps to promote the development and maintenance of secondary sexual characteristics. That's Turner's syndrome. Now, how about Klinefelters? A few things about Klinefelters. This syndrome is a condition of testicular dysgenesis, accompanied by the presence of one or more extra X chromosomes in excess of the normal male XY complement. Males who have Klinefelter syndrome has one extra chromosome. Although the presence of the extra chromosome is fairly common, it is still a rare diagnosis, as the phenotype is again variable. Many men can live their life without being aware that they even have this additional chromosome. Management of Klinefelter syndrome requires a comprehensive neurodevelopmental evaluation. In infancy and early childhood, this often includes a multidisciplinary approach to determine appropriate treatments such as physical therapy, infant stimulation programs, and speech therapy. For those males who have Klinefelter syndrome, congenital hypogonadism, which results in an inability to produce normal amounts of testosterone, accompanied by an increase in hypothalamic gonadotropic hormone, these individuals may receive some androgen therapy. Mitochondrial gene disorders come from nuclear DNA abnormalities, where there are multiple disease-causing rearrangements and mutations that occur in the mitochondrial DNA. Because mitochondrial DNA is inherited only from the mother, all disorders of mitochondrial DNA are also inherited on the maternal line. Mitochondrial DNA mutations generally affect tissues that are dependent on oxidative phosphorylation to meet their high needs for metabolic energy. Therefore, these disorders frequently affect the neuromuscular system and produce disorders such as encephalopathies, myopathies, retinal degeneration, loss of extraocular muscle function, and deafness. These diseases can be broad. They may include the liver, the bone marrow failure, the pancreas, islet cells that can dysfunction, and diabetes. We will now move to talk about environmental influences. Let's now talk about disorders caused by environmental influences. Environmental influences that include things like tetragenic agents, radiation, chemicals and drugs, and infectious agents. So when we're talking about tetragenic agents, we're talking about chemicals, physical or biological agents that produce abnormalities during embryonic or fetal development. Tetragenic agents can cause birth defects in three ways: direct exposure of the pregnant female and the embryo or fetus to the agent, through exposure of the soon to be pregnant female to an agent that has a slow clearance rate, with such that the tetragenic dose is retained during early pregnancy. And third, as a result of mutagenic effects of an environmental agent that occurs before pregnancy, causing permanent damage to a female or a male reproductive cell. When we talk about radiation, heavy doses of ionizing radiation are tetragenic and mutagenic. They have the capacity to affect inheritable change in genetic materials. We know that radiation has been shown to cause microcephaly, skeletal malformations, and mental retardation. When we think about chemicals and drugs, we know that drugs are at the top of the list for chemical tetragens. These many drugs cross the placenta and they expose the fetus to both the pharmacologic and tetragenic effects. Lipid-soluble drugs tend to cross the placenta more rapidly and enter the fetal circulation. The molecular weight of a drug also influences the rate and the amount of the drug transferred across the placenta. Medications that have been considered tetragenic are medications like thalidomide. And what it can do is it can cause photomelia, which is like a flipper-like appendage that will be, the fetus will form. Other drugs such as warfarin, ethyl alcohol, and cocaine are also tetragenic. In 1993, the U.S. Drug and Food Administration established a system for classifying drugs according to the probable risk to the fetus. The system goes A, B, C, D, and X. Drug categories of A are least dangerous, category B, C, and D increasingly more dangerous, whereas category X, that's a contraindication. Alcohol syndrome is a result of infants or fetuses being exposed to alcohol. We know that drugs and alcohol can have deleterious effects on the fetus. The term fetal alcohol syndrome is referred to a group of physical, behavioral, and cognitive fetal abnormalities that occur secondary to drinking alcohol while pregnant. Alcohol, which is lipid soluble and has a molecular weight between 600 and 1,000, passes freely across the placental barrier. Concentrations of alcohol in the fetus are at least as high as that of the mother. One thing about alcohol is it has a widely variable effect on fetal development. It can lead to prenatal and postnatal growth retardation, central nervous system involvement, neurologic abnormalities, developmental delays, behavioral dysfunctions, intellectual impairment, skull and brain malformations. The amount of alcohol that can be safely consumed during pregnancy is unknown. Small amounts of alcohol consumed during critical periods of fetal development have been seen to be teratogenic. Cocaine use, any drug use, has been shown to have negative effects on an unborn fetus. The, the effect of cocaine is not only on the fetus, but also on the mother. It has been shown that the use of cocaine can contribute to maternal hypertension. It can also contribute to preterm labor through stimulation of uterine contractions and reduction in the fetus size due to fetal vasoconstriction and reduction in blood flow of the placenta. Although most birth defects are related to exposure to a teratogenic agent, deficiency of nutrients and vitamins may also be a factor. Folic acid has been implicated in the development of neural tube defects. Studies have shown that significant decrease in neural tube defects occur when folic acid is taken long term by women of reproductive age. It is therefore recommended that women take zero point 0.4 milligrams of folic acid daily and then continue upon becoming pregnant. Many microorganisms cross the placenta and enter the fetal circulation, often producing multiple malformations. The acronym TORCH stands for toxoplasmosis, other, rubella, cytomegalovirus, and herpes, which are the most frequently implicated in fetal anomalies. Other infections that can cause fetal anomalies include things like varicella zoster virus infection, syphilis, tuberculosis, HIV. Some of the clinical manifestations we see can be growth retardation and abnormalities of the brain, microencephaly, anemia, thrombocytopenia, pneumonitis, myocarditis, congenital heart disease. Effective genetic counseling requires accurate diagnosis and communications of the findings and of the risk of reoccurrence to the parents and other family members who need such information. Counseling can be provided after the birth of an affected child, or it may be offered to people that are at higher risk for having an affected child. Usually, this education is provided by individuals who are trained counselors that can help the family understand the problem and support them and educate them and allow them to make decisions whether or not they want to have more children. Assessment of genetic risk and prognosis usually is directed by a clinical geneticist, often with the aid of labs and other clinical specialists. The assessment will usually include a detailed family history, a pedigree, a pregnancy history, detailed accounts of their birthing process, postnatal health and development, a careful and comprehensive physical examination, and laboratory tests, which would include chromosomal analysis and biochemical studies. The purpose of prenatal screening and diagnosis is not just to detect fetal abnormalities, but it's also to help reduce the anxiety and provide assistance to prepare parents if they are if they have a child with a specific disability. There are multiple methods that are utilized in helping to diagnose a fetus regarding genetic disorders. It includes things like ultrasound, maternal serum screening tests, amniocentesis, and percutaneous umbilical fetal blood sampling. When we talk about ultrasounds are non-invasive. They can help assist the provider in understanding the fetal size, position, the amount of amniotic fluid, and the placental location. Maternal serum markers can be utilized to assess first trimester screening between 11 and 13 weeks, looking for the risk of a fetus being born with trisomy 21, 13, or 18. Chorionic villus sampling, as well as percutaneous umbilical cord sampling. These are invasive procedures. They are not performed unless there is no other way to get the information regarding the assessment. When we talk about chorionic villus sampling, it obtains tissue that can be used for fetal chromosome studies, DNA analysis, and biochemical studies. Percutaneous umbilical cord sampling is an invasive procedure that does a transcutaneous insertion of a needle through the uterine wall and into the umbilical artery. It is performed under ultrasound after 16 weeks of gestation. It is used for prenatal diagnosis of hemoglobinopathies, coagulation disorders, metabolic and cytogenic disorders. Let's conclude this lecture with talking about the purpose of a prenatal diagnosis. One is information. It's helping the patient to be informed. Two, it's reassurance. If they are at risk or if they have anxiety, it will help to reassure them. And three, it gives them knowledge of the presence or the absence of the disorder. And then they can make an informed decision. The next few slides of this lecture are what I refer to as knowledge checks. There will be a question and then the answer will be on the preceding slide. The final slide in this lecture directs you to go to Module 2, and there is a case study that has been added to Module 2. That case study will help you to be able to apply the content from the genetics lecture into practice. You can work through the case study at your pace, and then on Thursday, the answers will be made available to you. But I really want you to try to see if you're able to apply this content into a clinical setting of a patient.